main focus for today is, we're going to do a quick presentation and then do some hands-on skills. And the focus primarily is going to be on patient assessment, making an accurate assessment, making appropriate designation choices, and seeing how things go out there in the field. Really, we're going to cover shock, correlating back to the trauma. We're talking about destination choices and why so many doctors are looking at wanting us to go to trauma centers versus your local EDs. So as we get into it, we're going to go see shock. What is it? It's quite simply the inability to refuse bonding. The body's shut down, it's given up. So you have the initial onset, the compensatory, progressive, and then of course refractory, irreversible, and death will soon ensue. So on onset, this is from the time of the incident to within the first 30 seconds. You're going to have that either blood loss, infection, whatever it might be. So you're going to see very little changes in what the patient's presenting like, whether they're standing here talking to you like I am, they're sitting in their car, laying in their bed at home. They may or may not have an elevated pulse rate. But there is a known source of the shock, so you just got to identify what it's coming from. So, for example, in the trauma, your bites or stings, whatever it might be there. Next stage is going to be compensatory stage. Here you're going to, it's between 30 seconds to 48 hours, and that really depends on what type of shock you're referring to. It's not hard and fast, that's the time set. You're talking about somebody that has their leg amputated. They can go from the initial through the compensatory to progressive shock within, a minute. So, but in the case of a patient where they may be looking at being septic, that 48-hour time period, they might require that full period before they actually get to that next stage. But you're definitely going to see some changes. Your MAP is going to drop to about 10 to 15 from the patient's norm. So, vitals are always good, and you need to monitor that blood pressure very closely. You're going to start looking at blood loss or fluid or total volume loss of roughly around 1,000 plus milliliters. And then, of course, you have your physiological changes progressing in there with the vasoconstriction, the reduction in urine output, and you're getting the fluid shift from interstitial spaces. And of course, the main goal of that is to preserve the heart and the brain. In the progressive stage, there it goes. Your body has reached loss of about 15 to 20% of its volume. You're going to see your heart rate go up, your blood pressure drop, and your respiration rate, of course, they're all going to elevate. And there, your blood losses, your BACs drop more than to about 20, and the fluid loss is almost 2 liters. So that's what you're really starting to look for. If you see this, it's aggressive treatment on these patients. So you're going to see hypoxia. You're going to start seeing there's a lack of blood flow. You're going to start having a lactic acid build up in the body. The body's basically just becoming a complete toxic environment. And as it goes to here and towards the end, and you enter into the refractory and reversible stages, you have complications that have arisen because of low lactic acid, because of the loss of blood flow in your different parts of your body. You have cellular death occurring. The body's starting to go on the mods, which is terrible. And then leading respiratory arrest, cardiac arrest.
So we're doing septic shock right now, correct?
No, this is any shock, really.
Yeah.
Yeah, but your body, you also have to look at it. Trauma patients, as you lose blood, what's happening? You have reduction in the blood flow, right?
Right.
So your body is metabolizing itself to keep the brain and the heart alive. So it's getting energy from somewhere. So, and of course, your oxygen's not circulating. So what's happening? I mean, it's there. It's going to be more predominant in a septic patient than in a traumatic patient. So, and of course, you have types of shock. You have hypovolemic, of course, from blood loss, fluid loss, distributed, which is your sepsis and anaphylactics, cardiogenic, from infarctions, cardiomyopathies, and obstructive, basically, otherwise. So if you go back to the old days where they remember the my shrimp can, everybody remember that one? Never heard of shrimp can? Sepsis, hemorrhagic, anaphylactic, insulin, respiratory, cardiogenic, anaphylactic, neurogenic. I forget what's P. Yeah, it was all of them, but then they boiled them down, they put them in, said, okay, out of all these different types of shock, they fit in these basic majority categories, and that's where these categories come from. So in hypovolemic, of course, it's either internal or external. It's going to be trauma, GI bleeds, AAAs, look for it. And they usually go through those stages of shock rapidly, and you want to consider their comorbidities. So whether they have a history of heart disease, cancers, things like that, this is a big factor for all of them. Anaphylaxis, of course, your body's exposed to the antigen or allergen, bites and stings. It could be a blood pressure med. Most common is going to be your ACE inhibitors. Those folks are usually on the drug for a while, and then one morning they just woke up and their face is swollen. Oh, I must have got bit by something in the middle of the night. You look at their meds and you'll see it's the frills that you're looking for. And of course, what are your signs and symptoms? Your wheezing, your edema, your tachycardias, hypotension, hives, and rashes. Neurogenic, specifically brain. There's some form of head trauma. It is always caused by trauma. So, head injury, spinal trauma, spinal taps, anesthesia, insulin reactions. Cushing's triad will always be present. You have your winding pulse pressures, your hypertension, and bradycardia in these patients, and they will be warm and dry. They don't present the same as your normal shock patient. This is a very abnormal setting, but you'll always see some type of trauma related to
You also have an erratic breathing.
Yeah.
It's very erratic.
Cheyenne strokes.
And when you see those three things, stand back and vomits coming projectile. Ugly.
Go ahead and drop that tube.
You're in trouble.
Yeah.
Down up.
Yeah. It's a bad day.
It's a
So
really
you
bad
gotta
call.
be on the lookout for it and be prepared and run as fast as you can. And cardiogenic, of course, pumps broke. Decrease in MAP and CO. You're going to start hearing some crackles in the lungs from fluid backing up. Causes from an MI, thoracic dissection, cardiomyopathy, pericarditis, mitral valve regurgitation, something of that nature. There is something majorly wrong going on with the heart. But your most common one will always be your MI. And of course, we're doing great finding those, but it's the other ones that we just need to be on the lookout for. So, on the sepsis. So, sepsis is grossly missed. It's very underdiagnosed. It kills a lot of people. Why? Because when we look at it, you go to that patient that, I have knee pain. I came to you 4 days, the last 4 days in a row, I told you to the hospital. What's going on? Is there changes? Is there sight swelling? Is there redness? Is it hot to the touch? That patient is early onset sepsis. This is where he can make the biggest difference. He needs to have lactates and things poured on him because the body is actually fighting some form of infection. Be tendonitis, plantar fasciitis. They could have had an animal bite, a dog bite, could come from gangrene, but there's something going on. So basically what you're going to see is you have some form of infection that's starting, and then they're going to go into your systemic inflammatory response syndrome, your SIRS. And what you're looking for as they make this progression, you have your source infection, the release of the toxins, you have an inflammatory response, leading to sepsis, then death. So this is your SIRS criteria. This is what we're going to look for. The suspected or known infection. Find it. A heart rate greater than 90. Well, 90 is a normal heart rate. But you sitting in that chair right there should not have a heart rate of 90. If you do, there's something wrong. Or if their respiration rate is greater than 20. You know, do they have a history of COPD, CHF, where, okay, that might be normal for them, but maybe not? That's a sign. A temperature greater than 100 or less than 98.6. Sepsis presents in 2 stages. No, yeah, 96.8, sorry. I can't read. So, typically when we hear sepsis, we're thinking infection. Of course, they're going to have a temp, they're going to be hot, they're going to be dry. But the second stage of sepsis, severe sepsis, they're not going to be hot. They're going to be cold. They're going to be hypertensive. They're going to be barely responsive. So, in those patients, you usually do not make a turnaround. Those are the ones that you're usually going to die. Your solid blood pressure, of course, less than 90. Once again, that's a very late sign. Most of the time, you'll see these patients with normal or maybe even slightly hypertensive or pre-hypertensive blood pressures. Urine's tea color. We can't pull labs in the field, but if someone says their tea is dark brown, now you have, yeah, that color. The body is breaking down things and metabolizing the body itself to break good energy because you're losing volume. The body is pulling water back from the kidneys, back into the circulatory volume, and that's where you get your dark urines. And of course, another late sign, and most of the time what we see is very lethargic patients. They're alert, they're oriented, but they're just fatigued and look. That's lethargy. They are early onset sepsis. And of course, you want to look for your comorbidities, your heart problems, your cancers, whatever, you know. When you see that bag of medicine in that 90-year-old room, or that 58-year-old person's bedroom, those are all extra problems that can complicate sepsis.
It's not to be confused with a hangover, right?
Yes. Yes. If they look like a hangover for the last 4 days, they're sick. They are truly, truly sick. So when you look at it, sepsis can come on so early and so rapidly that it will kill you within 3 days when it's not treated appropriately. That's why you see so many more doctors out there doing surgeries now, giving you prophylactic antibiotics as soon as you come out of the surgery room. The most common source infection post-surgery is going to be a staph infection of some kind.
Septic people also, when it gets to that dark urine and all, they have a smell. That's something unique smell.
Sometimes you do.
Sometimes.
Sometimes you do. So what are we looking for? We're looking for our sources, either trauma, the infections, or the history of the patient. Skin can either be cool and clammy, it can be hot and dry. You can have hypertension, or you can have hypertension, right? So now we're looking at multiple different things in the patient, different areas. It's just not the norm. You know, we think shock, we think cold and clammy skin. No, it's not necessarily that. You know, level of consciousness. So what are we going to do for them? Full set of vitals, everything we got on the truck. That's going to be your, you know, your blood pressure, it's going to be your SpO2, it's going to be your CO2, a temp, your BGL. These are all vital signs for these patients, and every one needs to be attained at some point in time. Because then it's going to give you the picture.
Yeah.
Just do the normal thing with the forearm.
Yeah, that's what I do.
Let me put your hand.
I understand half the time that thing doesn't work, but when you put it on there and it comes up and they feel really, really hot and it says 94, yeah, there's probably something wrong. There's nothing wrong at all and say, hey, my thermometer doesn't work, but my gut says they have fever.
Oh, yeah, we do that all the time.
So, aggressive fluid resuscitation. So you can start out with 2 liters fluid, For about every liter of blood that you lose, you need about 2 liters of normal saline to compensate. Monitor with 12 lead. A lot of people miss it. I recently, within the last couple months, had a septic patient that came out as a bleed laceration, where the gentleman was actually had a urinary catheter, blood clot inside, recent kidney stone removal surgery. Get there, he's lethargic, he's very hot, he's quadriplegic, he's septic. You just see him, he's just that sick. Well, before we turn the Brunswick kid at 12 lead, 12 lead comes out, acute MI. So, your patients can be having a STEMI on top of all this mess.
So did you turn around and get me here over there?
Yes. No, because that same day, they had 2 different sick patients coming in at the same time, and they were wondering why. Did they miss a STEMI? Did they miss a chest pains call? No, because we called in as a sick person initially, because that's what he was presenting. But when that 12 lead came out, and he flat out says acute MI on it with elevation of leads V1 through V4, reciprocal changes in 2, 3, and AVF, yeah, it's time to start moving. So arrhythmias will arise. These people are sick, and those 12 leads need to be got.
Suggested, we need a protocol for that. The only thing we got in place now is less than 90. Not to say we don't do it in the field, but suspected dehydration or seizures.
Sears criteria. And that's the big thing is, Sears criteria over in Europe is becoming a very, very large push. So when you look at Scotland and England, they're actually doing lactates in the field with a little device, and BioLink Scotland probably too.
BioLink does it also.
Yeah, but we're talking, BioLink, you gotta remember, is non-emergency or inter-facility transfers critical care, where they're doing point of care testing. The European systems are actually doing 911 side point of care. So when they come in, they can pull multiple lactates in the field, just like you would check a BGL for a diabetic.
You do it for them. They have a little box.
Yeah. But since we don't have that wonderful technology, what are we leaning back towards? Other signs and symptoms, that tea-colored urine. So when you look at those different things, then of course you want to address, you know, your tourniquets, your simple dressings, whatever. If there's bleeding, you need to take care of it, stop it. And O2 is needed. That's quite simply it. There isn't a whole lot really to this. Trauma's trauma. It's the other parts of shock that we need to identify, especially in the septic patients or cardiogenic and cardiogenic shocks that, you know, we need to really see and do for. Because trauma's easy, right? Air goes in and out, blood goes round and round, sticky side down in your wind. But the next part of it, for the class, what we're going to do is we're going to go do some skills. We're going to run through about 4 different scenarios. You guys are going to take turns taking lead. Your skills will be performed. If you need to intubate a patient, you need to intubate a patient.
That's in my office.
What's that?
Smoking weed. Did you say smoking weed?
No.
So I heard.
Well, then we're going to do Patty's scenario
That's what we heard.
All right. The sooner we can get through this, the sooner we can get out of here and enjoy the rest of the day, right? So,
Remind them that my office is not signed up.
so there's going to be a group here in the room with me. There's going to be a group going with Patrick out to the back, and we'll take a break. So as soon as you come back from the quick 10-minute break, we'll get you in, get you out. All right?